From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice. Here's your host.
Hello, and welcome to our listeners all around the world, and thank you for tuning in to this JAMA Clinical Reviews podcast. I am your host, Dr. Mary McDermott, Deputy Editor of JAMA, and I'm here today with Dr. Neil Iyengar, Associate Professor of Hematology and Oncology, Co-Director of Breast Medical Oncology, and Director of the Cancer Survivorship Services at the Winship Cancer Institute at Emory University. Dr. Iyengar is author of a JAMA Translational Review on the topic of obesity and cancer. Welcome, Neil. Thank you so much for joining me today.
Thank you, Mary. It's my pleasure.
So let's get started. And I'd like you to tell us how important is obesity as a risk factor for cancer, and particularly compared to other risk factors that we might more traditionally think of, like smoking, for example, or family history.
Well, certainly there are, unfortunately, several risk factors for developing cancers, and we've learned that the effect of these various risk factors varies from strong to moderate to weak. And for some cancers, I would classify the effect of obesity as moderate, and for other cancers, perhaps more on the moderate to weak side. And this is in the context of genetic risk factors and the environmental exposures that you mentioned. But the other piece that is important to keep in mind is that obesity is certainly a complex physiologic state that acts as a risk factor by itself, but can also compound risk when present with other risk factors such as environmental exposures. And given the prevalence of obesity worldwide, this is a risk factor that I would really consider to be moderate on its own, but even moderate to high when combined with other environmental or even genetic exposures.
Is obesity a risk factor for all cancers or some? And if some, can you let us know which ones are more associated with obesity?
Currently, obesity has not yet been associated with all cancers, and I say that because the data are evolving. There are 12 cancers that are strongly recognized to be associated with obesity, and this includes endometrial cancer, esophageal, gastric, kidney, colorectal, liver, gallbladder, pancreas, prostate, postmenopausal breast, ovarian, and thyroid cancers. But that being said, we are seeing growing data suggesting that there may be additional cancers that are also associated with obesity.
Would you say there's a threshold BMI above which the risk increases? Is there a dose response?
There does appear to be a dose response in terms of risk of these cancers. The strongest threshold or the most apparent threshold is a BMI of 30 or greater. However, for some cancers, like postmenopausal breast cancer, for example, we start to see the risk rising at a BMI of 27 or greater. And for other cancers, we start to see the risk rising at a BMI of 25 or greater, for example, colorectal cancer. So overall, a BMI of 25 or greater, which is consistent with overweight or obesity, appears to be associated with obesity-related cancers.
Now, your review summarizes biologic pathways by which obesity appears to increase the risk of cancer. Would you talk about a couple of these biologic pathways for us, please?
So obesity is a state of energy imbalance where essentially the body is overloaded with excess energy, and this causes stress to several organ systems and physiologic processes. One of the main effects of obesity that can give rise to cancer is the development of dysfunctional adipose tissue. Our adipose tissue is really meant to store energy, and when it is overloaded, either by excess caloric intake or inadequate caloric expenditure, the adipose tissues expand and grow through hypertrophy and hyperplasia. Ultimately, this can lead to overexpansion of adipose tissue, and normal energy storage function is disrupted. This leads to a number of effects, including inflammation and the leaking or spillage, if you will, of free fatty acids into the circulation, which can then ectopically deposit on skeletal muscles or other organs, which can then further inflammation and increase insulin resistance. And ultimately, the adipose tissue, which oftentimes surrounds organs where cancers can arise, can directly contribute the energy source in the form of free fatty acids to developing cancer cells and support the growth of tumors. Now, there are other processes that can also lead to cancer development. Obesity does impair the ability of the immune system to recognize and eliminate tumor cells, and it does this by altering the type of immune cells that are present in the adipose tissue or the tumor microenvironment and in the circulation, and by altering the function of immune cells. For example, cytotoxic T cells and natural killer cells can recognize developing cancer cells as foreign cells, if you will, and eliminate them. But in the setting of obesity, we see fewer populations or numbers of these types of immune cells. We also see that these types of immune cells can become dysfunctional because the actual machinery within the cell, which is used to eliminate the developing cancer cell, becomes almost paralyzed by the deposition of lipids and free fatty acids. Now, we also see alterations in energy metabolism. So cancer cells themselves, developing cancer cells, can alternate their energy metabolism to really utilize the adjacent energy stores depending on the type of environment that cancer cell is developing within. And this can alternate between respiration, cellular respiration, aerobic glycolysis, beta oxidation of fatty acids. Ultimately, what we see is an opportunistic switch in energy metabolism and an overabundance of energy, such that the cancer cell can leverage both metabolism switch and excess energy to grow. Additionally, we see alterations in processes that are involved in DNA repair. Many of these processes that I've just described can cause DNA damage in normal epithelial cells. And that DNA damage then may not be repaired efficiently in the setting of obesity. And this can be exacerbated additionally by the presence of genetic syndromes like alterations in the BRCA1 or BRCA2 genes. Finally, I would like to also mention an emerging area of research where we're seeing now, I would say, a significant amount of evidence suggesting that obesity not only alters our microbiome in the gut, those alterations then can further cause a systemic inflammation as well as alterations in metabolites that are produced by the gut microbiome, which can impact tumor growth. For example, butyrate is a protective metabolite, a short-chain fatty acid that can be produced in lower amounts in the setting of obesity. And we see other inflammatory metabolites that are produced by the gut microbiome in the setting of obesity. Ultimately, what we see in the microbiome is a shift in commensal and opportunistic bacteria. So more opportunistic bacteria that are producing metabolites that negatively impact cancer risk or that promote cancer risk, and fewer commensal bacterial populations, which translates to a reduction in protective metabolites. So these changes occur oftentimes together and not in isolation, which can generate microenvironments within various organs or tissues, as well as a whole body environment that is supportive of tumor growth.
Thank you. Let's talk about weight loss and how that might mitigate the risk of cancer in people with obesity. Do we know whether weight loss through behavior change can reduce the risk of cancer?
So we've certainly seen observational data which supports the hypothesis that weight loss through behavioral change, that's altering diet and exercise patterns to support weight loss, may be able to improve cancer risk. But I think the challenge here is there does seem to be a threshold of weight loss that is necessary to really move the needle and improve cancer risk. And that threshold appears to be around 10% weight loss. Most diet and exercise interventions have resulted in weight loss between 4 to 7% of baseline body weight. And in some observational studies, that level of weight loss has been associated with a reduction in the incidence of obesity-associated cancers. But in other studies, that has not been associated with a reduction in obesity-associated cancers. There have been some prospective clinical trials that have tested behavioral interventions. And again, it appears that lower levels of weight loss, less than 10%, have little to even no effect on reducing obesity-related cancer risk.
Do we know if certain types of cancer are more responsive to the benefits of weight loss in terms of development or progression?
Absolutely. So it does appear that colon cancer, for example, can be particularly sensitive in terms of risk reduction from weight loss. We also see some other cancers like endometrial cancer and breast cancer that are sensitive to weight loss as well. But again, this tends to be with higher levels of weight loss.
Now, I want to talk about the GLP-1 receptor agonists. What is the evidence regarding their ability to reduce risk of cancer?
The predominant evidence available to address that question is really observational. We've seen now some retrospective studies and nationwide cohort studies or registry studies that have looked at the relationship between GLP-1 receptor agonist use and cancer incidence. Now, many of these studies have involved predominantly patients with diabetes, where the GLP-1 receptor agonist is dosed for the treatment of diabetes. And this dosing can be different than obesity treatment. So we have to keep that in mind as we interpret the data. The observational studies, however, have shown overall that GLP-1 receptor agonist use is associated with a lower risk of most obesity-associated cancers. And this appears to also be a dose-response relationship where greater weight loss appears to have a greater effect. We do need prospective data to validate these observational findings, but it does look promising. And we're also starting to see data in patients without diabetes, those who have obesity but not diabetes, where the effects of GLP-1 receptor agonist-induced weight loss appears to possibly have an even greater protective effect on cancer risk.
And do we think that the potential benefits of the GLP-1 receptor agonists in this respect are mainly by way of weight loss, or could there be pleiotropic effects that are also benefiting patients?
That's a great question. So far, the evidence suggests that the predominant effect is likely through weight loss, and that weight loss may be reestablishing energy homeostasis, which then reverses a lot of the pathophysiologic issues that we previously discussed. There are studies, either ongoing or small preclinical studies, which suggest that there may be other effects, either immune-mediated effects or hormonal effects, that may also be helpful in reducing cancer incidence. But I would say this is an area that we don't have much data in yet in terms of a direct effect of GLP-1 receptor agonist mediated impact on cancer risk. Now, I will say that this is an area we talked earlier about behavioral interventions. I do think that this is an area where combining interventions could be really useful in that GLP-1 receptor agonists are very good at inducing weight loss, but where we struggle is understanding the optimal strategies for maintaining that optimal weight. And this is where lifestyle interventions may be ideal for long-term maintenance of optimal weight.
How about metformin? Is there evidence that metformin might reduce cancer risk?
So there's a lot of preclinical data indicating that metformin can reverse many of the pathophysiologic processes that we've discussed. For example, metformin can be helpful, certainly in optimizing systemic insulin signaling, but we also see data suggesting that metformin can help reduce the impact of oxidative stress and DNA damage, and perhaps even inflammation as well. So the preclinical data raises the hypothesis that in humans, metformin may be a useful approach for reducing risk. However, to date, we have predominantly observational data with regard to the impact of metformin on cancer risk. While some of it is supportive, the data is largely mixed or heterogeneous. So ultimately, we don't yet have enough data to recommend across the board that patients should take metformin for the reduction of cancer risk, but we do have ample data supporting further research in this area.
I'd like to ask you, what do you tell your patients diagnosed with cancer about their diet, given what we've discussed today, but also knowing that patients, say, undergoing cancer treatment need to maintain good nutrition? Do you tell patients with cancer who have overweight or obesity to work on weight loss?
That's a great question. For a very long time, and even to this day, oftentimes weight management and lifestyle are overlooked during or even after cancer treatment. We are now seeing more and more data to indicate that maintaining an optimal weight, maintaining an active lifestyle, and consuming an optimal diet certainly is important in terms of mitigating cancer treatment-related adverse effects, cancer-related symptoms, and generally improves quality of life for patients who are undergoing cancer treatment. There are emerging data now which indicate that lifestyle interventions like exercise and diet and maintaining a healthy weight may even improve cancer outcomes. We've seen data, randomized control trial data, indicating that exercise after a colon cancer diagnosis improves both cancer-specific survival as well as overall survival. We also have emerging data indicating that a plant-forward diet, which is either a plant-based diet or a plant-predominant diet, where 80% of one's meal consumption or dietary consumption comes from minimally processed plant-based foods, may be associated with improved cancer outcomes as well. Certainly, preclinical evidence indicates that exercise and a plant-based diet improves a lot of the pathophysiologic mechanisms we've discussed that negatively impact cancer outcomes. So ultimately, to answer your question, I certainly advise my patients to maintain an active lifestyle as best they can during cancer therapy, but certainly after cancer therapy. And we have guidelines from the American Society of Clinical Oncology and the American College of Sports Medicine indicating 150 minutes per week of moderate intensity exercise. We also have guidelines from the American Institute for Cancer Research indicating a plant-forward diet and reducing consumption of highly or ultra-processed meats, particularly ultra-processed red meats, which may also improve cancer outcomes as well. This is the type of guidance that I provide my patients, and I think we really need to get to a place where we can routinely incorporate exercise prescriptions and even dietary prescriptions into our cancer treatment plans as we generate more data showing that we can improve outcomes with lifestyle interventions and maintenance of optimal weight after a cancer diagnosis.
With regard to the increasing rates of cancer among younger people, is this tied to a higher prevalence of obesity among younger people, do we know?
Well, certainly it parallels the higher prevalence of obesity, and we've again seen from population studies that the cancers that are increasing in incidence, as you've indicated, in younger people are the obesity-associated cancers. And some of these population studies have used statistical techniques to control for other contributing factors like environmental exposures, smoking, for example, and obesity emerges as an independent predictor of cancer risk in those younger patients. Now, there are likely additional factors that are contributing to the rise of these cancers in younger populations. But I do think, based on the evidence we have so far, that obesity is a central contributor to the rise in young-onset cancers.
This has been really informative. Is there anything else that you'd like to add?
Well, I think we've covered most of the relevant topics. I would just end by saying that given everything we've talked about, one of the most successful strategies, in my opinion, to prevent obesity-related cancers is to avoid obesity in the first place. I think it's certainly much more straightforward and perhaps easier to avoid obesity, or at least to reduce cancer risk by maintaining a healthy weight, than it is to be in a situation where one is needing additional therapeutics or additional interventions to reverse obesity. And the effect of reversing obesity on reducing cancer incidence, as we've been discussing, may not be as large as avoiding obesity in the first place. So that is really my number one piece of advice to patients who are looking to lower their cancer risk, and that is to try to maintain a healthy weight and avoid obesity in the first place.
I'm Mary McDermott, and I've been speaking today with Dr. Neil Iyengar about his JAMA translational review on the topic of obesity and cancer. You can find a link to this article in the episode's description. For more of our podcasts, please visit us at jamanetworkaudio.com. You can subscribe and listen wherever you get your podcasts. This episode was produced by Shelley Steffens at the JAMA Network. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.